Thank you, Prof. Yano. We will move now to next session. Dr. Abdullah Alzahran, consultant upper GI surgeon. He is presenting sleeve gastrectomy and Gerd and current status.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear colleagues, ladies and gentlemen, I'd like to thank you all for attending, and I'd like to have this opportunity to thank the organizing committee, in particular Professor Dahiyan, for giving me this chance to be with you. Sleeve gastrectomy has been always linked to gastroesophageal reflux disease, and in my presentation we are going to discuss this association and whether do they actually exist and whether or not we can make sleeve gastrectomy treat rather than cause gastroesophageal reflux disease. Montreal Consensus defined the gastroesophageal reflux disease when the reflux of the stomach content causes troublesome symptoms and or complications. These can be of atypical or atypical symptoms and can present with erosive or non-erosive esophagitis. The prevalence of gastroesophageal reflux disease is estimated worldwide to be around 20%, but that goes to 50 to 70% in obese individuals. Same for hiatal hernia, which is at around 10% in general population and goes to 40 patients in morbidly obese patients. Sindus and Sushur et al. Both found a very striking gastroesophageal reflux disease incidence in obese individual, and that clearly addressed the need for further studies about the role of screening those patients submitted to bariatric surgery, which patients are expected to have higher prevalence of gastroesophageal reflux disease other than all patients. The laparoscopic sleeve gastrectomy is nowadays a very popular procedure for its ease, technique, low complication profile, well-tolerated long-term outcome. And Chu et al. In a systemic review examined 15 studies, including gastroesophageal reflux disease as a primary or secondary outcome after sleeve gastrectomy. Of these, 4 studies found an increase in the prevalence of gastroesophageal reflux disease in comparison to 7 studies which found decrease. And they could not draw any conclusion from the systemic review. Leishon et al. In contrary studied 900 plus patients, and the gastroesophageal reflux disease prevalence was only 4%. And they proposed that the anatomical changes associated with the laparoscopic sleeve gastrectomy and the variety of technique adopted by surgeon may increase the gastroesophageal reflux symptoms following sleeve gastrectomy. There are several variables which have been studied describing the relationship between sleeve gastrectomy and gastroesophageal reflux disease. Among these is the hiatal hernia, which we know hiatal hernia predisposed to gastroesophageal reflux disease. Cercelli et al. Reported a very interesting outcome in their patients. In all patients who had a crural repair, the incidence of gastroesophageal reflux disease was very low, whether the patient had a gastroesophageal reflux disease preoperatively or not, in comparison to a very high gastroesophageal reflux symptoms for those patients who didn't have crural repair reaching to 23%. Several authors have emphasized the importance of careful identification of hiatal repair and hiatal hernia and repairing it during sleeve gastrectomy. The panelists in the International Sleeve Gastrectomy Expert in 2012, majority of them have agreed on aggressive intraoperative identification of hiatal hernia and repairing it during sleeve gastrectomy. Intragastric pressure was found to be normal as normal stomach, but it significantly increased with the occlusion and filling of the stomach with saline. And this high pressure and lesser distensibility will lead to adverse impact on symptom of gastroesophageal reflux disease. Hempens et al. Found a similar finding. In their studies, they found the patients post-sleeve gastrectomy have an instance of gastroesophageal reflux disease around 22% at 1 year, and that goes down to 3% at 3 years, and they attributed this to the increase in sleeve tube compliance with time. Fabrizio et al., through a pathophysiological studies of patient pre- and post-sleeve gastrectomy, have found great improvement in symptoms and control of reflux disease in morbidly obese patients, and they attributed this to the decrease in acid production and the absence of mid-stomach stenosis in their study. Weight reduction. We all know obesity associated with gastroesophageal reflux disease. So theoretically, if we treat obesity, can the gastroesophageal reflux disease be treated as well? Delayed gastric emptying is associated with gastroesophageal reflux disease. Melissus et al. Again found an interesting finding. In their patient, they found the gastric emptying and the lag phase has dramatically improved following sleeve gastrectomy. And they attributed this to the excision of the fundus, absence of receptive relaxation and alteration in the contractility of the proximal stomach, and they found in their study very low incidence of gastroesophageal reflux disease following sleeve gastrectomy. A lower esophageal sphincter tone is an important anti-reflux mechanism, and alteration in this may lead to gastroesophageal reflux disease. Bragato et al. Observed reflux symptoms in 27% of their patients, and majority of them had lower esophageal sphincter post-operatively from 14 to 10.5 millimeter of mercury 6 months post-operatively. The Petersons et al. In contrary found significantly increased lower esophageal sphincter from 8 to 21 millimeter of mercury, and they attributed this to the difference in the surgical technique. And they concluded that increased lower esophageal pressure was dependent on the position of the stapler closer to the angle of Hess, but not transecting the sling fibers. Proximal gastric pouch is a known risk factor for reflux disease, and Carter et al. Reported significant increase in gastroesophageal reflux disease in their patients. And in all patients, they found they went away from the gastroesophageal junction to avoid narrowing. Keder et al. Found the same finding. Combination of dilated upper part of the sleeve with relative narrowing in all their patients who reported to have gastroesophageal reflux disease post-operatively. Mid-gastric narrowing was found to be associated with reflux disease as well. Diaz et al. Observed significant decrease in gastroesophageal reflux disease by avoiding narrowing of the junction of the vertical and the horizontal portion of the sleeve, removing all the fundus and routinely repairing the hiatal hernia. And Keder et al. Observed similar finding. Relative narrowing of the mid-stomach in all their patients who had gastroesophageal reflux disease. A proximal gastric migration found to increase regurgitation symptoms, and Pullman et al. Demonstrated migration of the proximal sleeve in 10 out of 27 patients, and in majority of them, reflux regurgitation symptom persisted in comparison to a very low regurgitation symptoms in those who did not have sleeve herniation. And therefore, if we could recognize all these risk factors and take care of it, applying standard sleeve gastrectomy technique, could we have gastroesophageal reflux disease under control, or that should not have any effect on the reflux symptoms? There are several anti-reflux operative techniques which we don't have time to go over, ranging from a total rab to a partial rab or fixation of the gastroesophageal junction. They are, however, all experimental and too early to evaluate. I summarized them for those who are interested to have it. You can have it from the control room. The post-sleeve gastrectomy GERD can be managed either medically or surgically. Several surgical options has been described. Among these, the standard technique is conversion to a gastric bypass, has been proven to be very effective in controlling gastroesophageal reflux disease. But has got its own complication. Re-sleeve gastrectomy has been described, and nurses et al. Described in their patients an algorithm of assessing those patients who are subjected to sleeve gastrectomy. And in their study, 4 patients were treated for gastroesophageal reflux disease. In all of them, they found the proximal gastric pouch, and transecting it, revising the sleeve, has resolved all the gastroesophageal reflux disease in those patients. Gastroesophageal reflux disease management with LINX system has been recently introduced, and there are several studies reporting a good outcome with LINX system, and cardiopexy with ligamentum teres has been described as well. In conclusion, sleeve gastrectomy should not be a contraindication to obese with gastroesophageal reflux disease. Standardized technique recognizing the factor we have discussed, which include the hiatal hernia, leaving no proximal pouch, avoiding sling fiber transection, avoiding mid-gastric narrowing, avoiding torsion and twist of the stomach, and avoiding migration of the stomach should have a good control on gastroesophageal reflux disease. Several technique has been described combining sleeve gastrectomy with other procedure, but they are still experimental and should be practiced with caution. Both sleeve gastrectomy, gastroesophageal reflux disease can be managed medically, and if intractable, gastric bypass, re-sleeve, magnetic sphincter augmentation system should be carefully selected considering the patient preference and long-term outcome. Thank you.
Question.
I'm Otto from Oita University, Japan. Thank you very much. Very nice review of regarding sleeve gastrectomy and GERD, and good presentation. I want to know the preoperative management before sleeve gastrectomy in Saudi Arabia, especially routine preoperative endoscopy before the operation is routinely performed in Saudi Arabia or not, because recent USA guidelines does not recommend it, but in Japan, we routinely performed endoscopy before bariatric surgery.
Thank you. In my hospital, we routinely do an upper GI endoscopy for all those patients presenting for bariatric surgery, and the reason for this is the high prevalence of Helicobacter pylori and other associated pathology. And if you look at the latest ASMBS guideline, they did comment on individualizing the need for upper GI endoscopy according to
because there is very low evidence only. So
yeah, and therefore they did clearly advise that should be according to the national finding of association of an upper GI disease, including Helicobacter pylori. Mm-hmm. So we do it routine, but there might be some other center doing it selective, but in my hospital we are routinely screening those patients endoscopically.
How about the screening of Helicobacter pylori?
We do it always.
Okay, thank you.
And we eradicate too.
Assalamu alaikum.
Alaikum assalam.
Dr. Walid Bukhari. Congratulations for a wonderful presentation. I have two things. Comment that usually, we know that in North America, 48% of people have hiatus hernia, but only 12% that will need attention, either surgical or conservative management. So what we do is we take patients with symptoms and endoscope them as mandatory preoperative conclusive evidence. One. Secondly, patients intraoperatively, as part of the procedure, we always explore the hiatus, and we strengthen that, because we found that patients who have choroplasty actually minimizes after, during 5 years post-operative, the occurrence of GERD. This is one. Second, what's your take on the occurrence after 5 years after sleeve of the Barrett's esophagus? The new reports that are coming out after sleeve gastrectomy.
I haven't encountered any one of our patients coming with Barrett's esophagus. However, we have a couple of patients presenting with gastroesophageal reflux disease post sleeve gastrectomy. They have been scoped, found to have esophagitis, but no Barrett's esophagus on them. Regarding what would be the treatment option for those who are having a Barrett's esophagus, again, that has been studied, and majority of the recommendation was to convert them to a gastric bypass for better control of reflux disease. But Michel Gagné has written a paper on this, and he was rather considering sleeve gastrectomy should not be a contraindication to those patients who are having Barrett's esophagus, claiming that if the sleeve gastrectomy is done properly, it should have control of the reflux symptoms. And again, for those patients who are having gastroesophageal reflux disease following sleeve gastrectomy, I think we should cautiously evaluate those patients, and we should be very careful in selecting whether to go for gastric bypass or re-sleeve. I honestly feel very concerned of re-sleeving patient. If I don't find a reason to explain the gastroesophageal reflux disease on those sleeved stomach, I would rather convert it into a gastric bypass.
Thank you very much, Dr. I really appreciate that we are doing routinely preoperative endoscopy for all patients going for bariatrics. The reason was because there was a study actually last year published in visit surgery for asymptomatic patients. They found 60% of findings, including of them 2% Barrett's. And they follow these patients after 5 years, and they ruscope them, and the Barrett's incidence jumped to 19%. So last survey, if so, 90% of the bariatric surgeon doing routinely pre-op endoscopy.
I agree.
Last question.
Thank you very much, Dr. Abdullah. Regarding the preoperative assessment of patients with heartburn with symptoms of GERD, do you go further into pH monitoring and manometry studies to really appreciate whether this is significant or not? Because really, if our patients get symptoms, we don't go for sleeve. We go further for to elaborate on the degree of the reflux based on these tests. So what do you think of this?
Thank you, Professor Mohammed. I agree with you. We are primarily relying on the subjective assessment of gastroesophageal reflux disease on those patients, relying on symptoms. And there has been many studies claiming that doing an objective assessment on those patients, you may find the incidence of gastroesophageal reflux disease is much less than what we are predicting. And in those patients in whom gastroesophageal reflux disease is diagnosed, I don't know whether, I know that some surgeons are considering sleeve gastrectomy a contraindication to those patients who are having an established gastroesophageal reflux disease, but I personally don't find it, if provided the standard technique has been respected. But if the standard technique is not well mastered, there are many surgeons, they fear getting closer to the gastroesophageal junction, leaving proximal gastric pouch. I would rather go for a gastric bypass. But I agree on objective assessment of those patients who are symptomatic preoperatively in order to know at least where we are standing. There are many studies reporting very high incidence of gastroesophageal disease, but if you look at it, you don't find them assessing the patient objectively. They are all subjective assessment.
Thank you, Dr. Abdullah.
And for medical legal aspect as well. Thank you.
Thank you, Dr. Abdullah. Thank you so much.
Okay, we'll go for the next presentation.